So if you see a patient with thrombocytopenia, leukopenia, bleeding, lactic acidosis, prostration, altered mental status, pulmonary edema, anything can be malaria, and you have to rule it out. And if you rule it in, you have to move quickly and treat that patient very, very quickly for the patient to survive. Let's put it that way.
Welcome to Critical Care Time, the podcast for everyone who cares for the critically ill. I'm your host, Dr. Nick Mark.
And I'm Dr. Cyrus Askin. Nick, what are you up to these days?
I had so much prepared to talk to you about, and it's all irrelevant because you didn't do your homework. Listeners, I told him we were going to talk about Andor today, and he has not watched season 2 or season 1. So I don't know. You can hear me rant about how great it is for an hour, or we'll talk about something else.
I've got a laundry list of television that I'm trying to catch up on, and it's a whole thing. And we're trying to finish up like the last few episodes of Suits. And yeah, so eventually I'll get to Andor, and I'll get to season 2 of The Last of Us and White Lotus, and so on and so forth. All of the shows that people say are like ridiculously great.
We have so much to catch up on.
I know. Hey, but for our listeners, they might see a few photos of us in Miami in a couple months. We're going to do a little family vacation, take some time away from the pod, hang out by the pool, hang out with the kiddos. That should be a good time. Maybe I'll watch a little bit of TV there too.
You better be caught up by then, man, because we've got a lot to talk about.
I'll do so that sounds good, but I don't think I'm going to have an opportunity to catch up today. I think we've got bigger fish to fry.
We do have some other things to talk about. So here towards the end of season 2 of Critical Care Time, we realized that we are yet to do an episode on fever. And we noticed, because we do read your emails, listeners, that many of you have requested an episode on not just fever, but fever in the returning traveler. So on this week's episode, we're going to kill both birds with the proverbial stone and talk about fever in the ICU and talk about an approach to the returning traveler who has fever and might end up in your ICU.
This is one of those topics that's highly represented on boards, and it does come along, infrequently, I suppose, for some of us, or maybe more frequently, depending on where you practice. We often have travelers, and especially like in my population, we often have folks that travel abroad and they come back sick, maybe come back with fever. And so the differential in that situation can be quite a bit larger than perhaps what we're used to. So I think really the key here is to recognize that as intensivists, we take care of the sickest of the sick. And sometimes the greatest tool we have is asking the right question. So hopefully at the end of our discussion today, we'll know what those questions are.
Absolutely. We are lucky to be joined today by an expert both in ID and critical care who can help guide us on this journey of fever in the returning traveler. There's a lot of exciting stuff. This is great test prep, but it's also great life prep. So get excited.
Let's do it.
All right. We are very fortunate to be joined by a guest who's trained in both ID and critical care.
That's right, Nick. So we're actually going to be joined today by Dr. Louise Tatem, who's board certified in internal medicine, infectious disease, and critical care. And of course, if that wasn't enough, he's also got a certificate in tropical medicine from the London School of Hygiene and Tropical Medicine. He's worked in Peru, Haiti, India, Honduras, and now most recently has the fortune or perhaps misfortune of working with Nick at Swedish Medical Center in Seattle, where he practices both infectious disease and critical care.
Louise, welcome to Critical Care Time.
Hi, guys. I'm pleasure to be here.
Thanks so much for joining us. I'm really excited to pick your brain about this topic. Maybe we should start off, though, by asking a question I ask all of our guests, like, what's your superhero origin story? Like, what got you into this? Why do you have this unique skill set?
What's my superhero origin story? Okay. Various mentors, I guess. Most of my mentors were ID, people that I admired the most during medical school and also during residency. Dr. Coyle and Dr. Curry in New York City, those make those great diagnoses. I do remember going to the ID week, the IDSA meeting when I was my first year resident, and I was at all by all the differential diagnosis brought up by experts, and that really, got me into it. Also, I love traveling, so traveling and tropical diseases go along the way, especially if you love the outdoors. So all that together brought me to ID. Then, of course, I do love internal medicine. I was that kind of a medical student that was never decided what to do, loved everything. And And that's why I went into internal medicine, and then I went into critical care too after the pandemic. And here I am. Yeah, yeah.
Nice.
It's awesome.
Next is nephrology. We'll see.
Oh gosh, unbelievable.
Great. Well, that's a great intro, and I'm excited to talk about kind of your experiences and some of those different places you've worked. But before we do that, maybe we should build a bit of a foundation for our listeners by talking about just some basics, like what is fever? Maybe we should talk about before we even talk about fever and the returning traveler.
I think, yeah, Nick, you're right. Fever is extraordinarily common. Of course, we see it in the ICU not infrequently. It's really one of the most common things, in fact, we see in the ICU and in our ICU patients. According to the IDSA, between this is a really really tight interval here, between 28 and 88% of ICU patients develop a fever at least once during their course. So yeah, definitely a good topic for us to cover.
In preparing for this episode, I tried really hard to find a good definition of fever. Luis, do you want to define fever for us? I mean, I feel like this is actually a really hard question.
Define fever. That's a philosophical question. I think. I think it's all relative, and our favorite word in ID is it depends. So it
Mm,
depends. It depends on your host. It depends on the environment. It depends on the disease you're talking about. So fever, I will define it as if the patient discloses to me that they feel feverish, I will believe them, especially if they come traveling or something like that. If he's in the hospital where I have more accurate, an accurate capacity to measure the fever, I follow more like the 100.4 persistently for 1 hour or 101, one episode, and it has to be, accurate. So I will like definitely instigate on that. But fever can be nothing if the patient is immunocompromised or have received NSAIDs or anything like that, or it can be something that very very profound in, for example, in hyperthermia just due to heat stroke or something like that. So what is fever is a broad definition, it's a broad topic that you have to approach with a lot of caution, I would say.
yeah, I think that's well said. I read a couple of good sources on this. According to Up to Date, which is an okay source, fever is an elevation in core body temperature above the daily range for an individual. There is no universal threshold for fever, as normal body temperature varies by individual, time of day, and method of measure. So very wishy washy.
Love it.
I went to the IDSA next, and they define fever just like you did, as the SCCM and IDSA definition is a single temperature measurement greater than 38.3, or as you said, a sustained measurement over 38 for an hour. Though also, as you said, in neutropenia, in the steroids, NSAIDs, all these things are out the window.
So yeah, lots of caveats. I think when it comes to fever, and I think Luis, I'm always reminded when we do this podcast of this idea that context is everything, and so it's important, I think, to tailor your definition of fever to the patient. Recognize that okay, a patient who I might see who's coming back from a training exercise, who was out in the desert where it was hot as hell for a long period of time, their temperature may be elevated, but not indicative of, perhaps an infectious fever or a fever due to an infectious cause versus someone who's, let's say, neutropenic returning traveler for whom your like level of suspicion is going to be astronomically high. And so, like anything that they say, they're like, I might have been feverish. I don't know. You're like, that's a fever. We got to investigate.
Exactly. I also asked the patients a lot if they had rigors, which is more associated with bacteremia or infections. So not only fevers for rigors and how the patient feels. Like not only fever can be one thing, and also understanding that most patients that will present to your ICU or your ER might be afebrile when they come in because they took something at home. So
Yep.
you got to be careful about what is fever. I hear a lot of times, oh, patient is afebrile. Really doesn't mean a lot. Talk to the patient and listen to them. If they told you they had a fever, they felt really bad, likely they are.
Right. That's a huge point, and I just have to say, I have, like, one ID pearl that I use, and you kind of stole my thunder, which is that, the rigors and the significance of rigors as it relates to bacteremia as being even more sensitive than the fever itself. I had to remember, like, distinctly asking an ICU nurse to draw blood cultures on someone who was rigoring, and they kinda argued with me. They're like, "Well, they're not fevering. Why are we doing this?" And I was like, "Well, you know, there's actually good evidence to suggest that this is really the best time to draw that blood culture. And then 8 hours later, it was 4 of 4 were positive, and I felt pretty good about myself. It was like the one time I actually felt good about myself. But anyway, yeah. So I think what I'm taking away from that is temperature in general, in broad strokes, 100.4 sustained for an hour, 101 at any point in time, context, 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 listen to your patient. And part of that context is travel history or contacts, maybe infectious contacts. Neutropenia is definitely something we need to worry about. Is that a reasonable kind of summary thus far?
Yeah, definitely reasonable. I will say the
Awesome.
context is everything.
I don't want to steal your thunder here, but I kind of had my mind blown in researching this episode, reading about what a normal body temperature was. So I think we were all sort of raised with this normal is 98.6 Fahrenheit, 37 Celsius, right? It's a nice round number. And it turns out it's just totally wrong. Um, I looked back, and so apparently there was this German physician, Karl Wunderlich, who in 1868 took this like foot long mercury thermometer around the hospital and measured like 25,000 patients' temperatures. And he didn't have a computer and he didn't have stats. So it's kind of unclear how he took like these like perhaps a million or more measurements and came up with an average. But anyway, that's where this 98.6 comes from. But it turns out that it's kind of wrong. They like dug his original thermometer out of storage. It was in a museum, and they measured it, and it was off by like 1.6 degrees Celsius.
Oh,
So the
dang.
normal body temperature is actually a bit lower than that. I also read in the IDSA that they looked at temperature going back to like people in the Civil War to the present, and the average or normal body temperature has been decreasing slightly, which they think might have to do with like less chronic inflammation, like fewer people with like TB and stuff in the population, and maybe slowing metabolism, which explains like, enlarging waistbands too. But anyway, I was shocked to learn that not only is body temperature changing over time, but it's not what I thought it was since I was a kid. So mind blown.
Yeah, there's great facts. Yeah, it's hard to imagine that maybe Carl Wunderlich might have transposed a number when he was writing down I guess what 60 to 75,000 digits that he was transcribing as he was seeing these patients and so on and so forth. Usually I find your tangents to be eye roll inducing, but this one's actually I think pretty good. So
So here's the back of the napkin now, the math that I'll leave you with. So it took like 20 minutes to measure somebody's temperature with this giant thermometer he had, because like you stick it in their armpit and then it takes like a while to like adjust. So if you do the math, like 25,000 patients times 20 minutes, that's like a solid year up in people's armpits. Plus, like, he did multiple measurements. So this guy had probably spent decades of his life measuring armpit temperatures. And he got it wrong. So, yeah, got to respect the game though. He tried.
you do gotta respect the hustle. So maybe we can now bring it back to 2025. And in doing so, let's actually riff off of that, Nick, and ask Luis. When you're in the ICU, do you usually go around with like a foot long or meter long thermometer and shove it in people's armpits, or is there maybe a better way to get their temperature?
I never thought about that. I think the best way to do is we asking your nurse, to measure the vitals, and that'll be the best way to do it. Sometimes you have a hard time, you have to do a rectal temperature, which is okay. But yeah. And like when there is a fever, I usually like to verify it. So I asked the nurse, can we just recheck that again and make sure that we're on the right track? Sometimes, the thermometer is close to the heating pad or whatever. So like you have to think about all these nuances in the ICU that you don't have in other places. The bear hugger is there. What's going on for real? Is the patient on CRT or not? Those things affect your temperature, and you have to, think of all that. Is patient on ECMO? Is that on ECMO? Whatever.
Right.
Yeah.
I think that's a great point. And one thing that I've really gotten to the habit of doing whenever I have a patient on ECMO or CRRT is looking at the set temperature on the water bath.
Mm-hmm.
Because sometimes like you walk in the room and the patient doesn't have a fever, right? But the water bath is set at like 25. And you're like, oh, that's doing a lot to cool this person. Like it's taking a lot of work to keep them afebrile.
Yeah, they've just
Yeah,
got like a endless supply of ice being kind of curried into the room to cool down that damn water bath, and you're like, "Oh yeah, they're not fevering." It's like, well, actually, they're most assuredly fevering. We're just masking it.
the same thing with the cooling blankets. So there's a lot of devices and nuance in the ICU. And is the patient getting around the clock NSAIDs? Is the patient getting steroids? So all these things will mask your fever. So it's all about context. And unfortunately, I wouldn't call it, per se fever. I will say like when you suspect an infection in a patient in the ICU, regardless of the fever, you have to have, a higher attendance to all these things that are happening with the patient. Um, because if we just say fever, then people just, fix on that. And unfortunately, that's not the way to approach this.
So maybe it's a little bit of a hot take, maybe it's not. And I love what you're saying, Luis, because what I'm taking away from this is maybe step away from the number on the thermometer and lean into the history and lean into your suspicion. And if your pretest probability, just based on the history and the exam, so on and so forth, is that I think this patient is infected, then perhaps you should just work them up for an infection rather than like hemming and hawing over the exact value on the thermometer.
Exactly. Yes, exactly.
That said, though, if you have, all of these invasive measurements in the ICU, sometimes we have very good numbers, right? Like
True.
I love it when somebody has like a PA catheter in, because that's like a gold standard for temperature, right? Like instead of using that like Jedi mind trick forehead thing that they
Right.
use, you can get like an accurate temperature.
But like for example, let's think about like the two biggest killers in our population, dengue and malaria. Most
Mhm.
of them, when the patient lands in the ICU, the patient might not be febrile. With dengue, for example, when the patient lands at the critical phase in the ICU, it's not febrile anymore. So don't, even if the patient is afebrile, the patient is acutely ill, has severe illness, and no fevers. In malaria, I don't know if you guys remember from medical school. I'm older than you guys. I assume, but like, so the quartan fever and tertian fever. So fevers are not permanent in malaria, for example. It's a cycle depending on the cycle of the parasite. So you might not have fevers when you present to the ICU or to the ER. Doesn't mean the patient is not sick. Doesn't mean the patient doesn't have a severe infection, life-threatening infection, but there's no fever whatsoever. But there is definitely multi-organ involvement. So thinking about these things in a broad category and like in a broader perspective is very important. And also when we talk about all the nuances of the ICU, where is the temperature being taken? Is in the axillary, which give you can be hypothermic, but can be a lower level. Is the rectal? Is it close to the heating pad? Is the patient on a cooling blanket? Is the patient on CRT? Is the patient on ECMO? All these things together. Yeah.
That's awesome. Those are like really great points. And so let's just for a moment, I know we're going to get into the returning traveler and there is some nuance there that I think we need to unpack, but
Yeah.
in general, when you have let's say a true fever, totally believe it, good story, so on and so forth, in your generic ICU patient, how do you approach them in terms of your quote unquote full fever workup?
So the first thing I assess is how stable is my patient. Is the patient about to die? Is the patient very stable? It's very different when I'm working nights in an ICU and randomly the nurse tells me the patient had a fever one episode and the patient is normotensive or hypertensive, versus a patient who's just got into the ICU and is on septic shock on two pressors. I approach
Sure.
those two scenarios very differently. So if a patient is case A, patient is very stable in the ICU, and all of a sudden the nurse tells me, hey, there is a temperature of 101. I go assess the patient. I will definitely ask the nurse to repeat the measurement for sure. And then I will look for things that might be triggering the fever. First of all, is the patient on the ventilator? If it is, ask the nurse, has the oxygen requirements increased or not? Is there a new infiltrate on the chest X-ray? Is the patient, having higher peak pressure, something like that? Also, what sedation is the patient is getting? Or we all know that Precedex can cause fevers. Also, other sedatives like ketamine as well. Is the patient getting any medication that can be pyrogenic as well? So all these things all together, can cause fevers. Also, is the patient on a heating blanket? I had those cases too. Like the patient was initially hypothermic, they left the heating blanket on. So all these things, if the patient is stable, but it's very different if I get a patient that just got into the ICU that I just admitted, is on two pressors, Is the patient ESRD? Does he has a line or doesn't have a line? Is this patient an IV drug user? Is this patient has a wound that we haven't looked up on? Is the patient on DKA and I haven't seen it? I thought it was only because of non-compliance, but like the patient can have other things. I had a patient, for example, that had DKA and had a perirectal abscess. Nobody knew about it, but because he had fevers, we went to look at everything else and found it. Also, neck fasciitis, for example, is something that can be very, very esoteric sometimes and hard to diagnose. But if you see redness, fevers, progression, so you have to keep it keeps your alarm set up and put everything in context. Is the patient stable, unstable? Is there a possible infectious cause of fever? And have I ruled out all the other non-infectious causes of fevers as well? That's the way I approach it.
And I before we move on, because I think Nick actually he had listed some of his sort of pearls for his full fever workup, which is very similar to how I approach this in the generic patient. But if we could just take a moment to unpack a little bit the drug fever. You mentioned Precedex or dexmedetomidine. You mentioned ketamine. Are there just some other common drugs that you would recommend our listeners keep an eye out if they're trying to look for a potential drug fever?
Where the classical drug is Precedex, but also antibiotics can cause fevers as well by itself. Drug reactions can cause fever as well that I remember. I believe hydrolysine, but I'm not quite sure. So quote me on that. I'm not quite sure about that.
That does sound familiar to me too.
Those are the classic drugs that can cause fevers
Got it.
in the ICU that I think about all the time.
Any other ones, Nick, that you can think of? Because I mean, he hit some of the big ones.
Antibiotics, big one. Yeah. Let's see. I'm going to use Dr. Google for some help here.
While you're looking that up for our listeners, I think I was reviewing your full fever workup, and I think it's similar to mine. Other than good history, skin exam that you mentioned, Luis, getting blood cultures, and I like to, if they have a central line, I'll usually check the line, get a peripheral as well, at least one. Look at the urine, look at their labs. If they haven't had a CBC recently, get a CBC with a white count and a differential, kind of see if we're looking at a neutrophilic predominance, something along those lines. I think getting a chest X-ray is often reasonable. It's typically something I'll get. The other one that is always interesting is the Foley, and what do you do with the Foley? Especially if they got like a chronic Foley, and that opens up like a whole can of worms.
It's got to go.
Yeah. So I will say, Cyrus, also like put everything into context, because sometimes I feel like in the ICU, we do things reflectively and start getting tests without anything. And I know in the ICU is very hard. As an ID doctor that after that became an ICU doctor, I will always like lose my head. Like when I was like, okay, why did they get a urine? This patient doesn't have any urine symptoms.
Yeah.
So in a patient that is sedated and on septic shock, you have to just go, all of the above, right? But it's a patient, if you can just go and talk to the patient, and ask them what their symptoms are and see, target your workup on those symptoms and things. If you feel that you're at a loss and like the patient cannot really communicate, then yes, all bets are off and you can continue to work up the patient, accordingly. That's one thing. Another thing that people don't mention a lot about fevers, thrombosis in the ICU is a very common reason for fevers that I have picked up a lot. And also take a look at the peripheral IV access. You'll be surprised how many times I go to the bedside and I examine the IV access and there is infiltration or thrombophlebitis on that arm. So we actually did a QI project during my fellowship, and we found a lot of thrombophlebitis as a cause of fevers as well. In those things that we don't think about that often. But yeah, so I will say I will start just go to the bedside, examine the patient. An ultrasound probe will be, great. The patient has, for example, a cirrhosis patient can have a very different etiology of fevers than a little old lady in the ICU for a pelvic fracture that just bled. Hematomas can cause fevers, so think about all these things and then put it into context. If the patient cannot communicate, then of course, go ahead and do your blood cultures, urine cultures, and all of the above. If patient can communicate, then you can go in a step approach to avoid, a huge workup. The blood cultures, it depends on the yield. Think about your pretest probability. A patient that is ESRD and is getting dialysis every day and came with rigors, of course, get blood cultures. But if a patient is in the ICU for 15 days, doesn't have a central line, and had one episode of fever, maybe I will hold off on that and wait. If the fever is persistent, then yes, I will get the blood cultures and think about it. But if not, then I would just, wait it out and see how the patient is behaving before going all of it, for that workup.
And I think it's a really important point to emphasize too that, if you test inappropriately, the risk of false positive may be higher than the chance of a true positive, right? So like drawing
Absolutely.
blood cultures in somebody with very low risk, right? And then you get something and you're like, is that a contaminant or not? I don't know. Circling back on drug fevers, I have a list here. Some classics: amphotericin B, good old shakes and bakes; antihistamines, anticholinergic effects; bleomycin, penicillin, phenytoin, procainamide. Not that we use that very often. And then salicylates. Interestingly enough, we often think of those as suppressing fever, but they can also cause them. And then sulfonamides. So actually, like quite a few to add, but yeah, very interesting.
So, and I was going to add one other kind of thing. So I'm glad that in my sort of like outlined full fever workup, that would definitely be more for the like patient is not able to communicate. I've got to sort of shotgun things to try to figure out what's going on. More of that patient you described earlier, Luis, that like two pressers really sick. Maybe they're just coming to you and for whatever reason, like you're needing to work them up broadly. But I think that's a very important point. It's like, again, context, pretest probability. If you don't have to paint with a broad brush, then don't paint with a broad brush. The other thing I was going to kind of mention on the point of fever is just as a brief aside is that the patient that's fevering with a hitherto unidentified cause of fever. And so what I always think of is, the sinusitis and the patient with the NG tube. I think about acalculous cholecystitis or calculous cholecystitis for that matter. I think of if it's kind of persistent fevers and bacteremia, I think throwing a probe on their chest and getting a formal echo looking for that endocarditis is reasonable. And then in addition, the sort of patient that's been on dexmedetomidine for days and days, and you're like, oh, maybe it's the dexmedetomidine. That's my like 30-second. Let's make sure we're covering these bases in addition to all the other things. I was just going to kind of put that in as a little plug. I don't know if that's jives with what you do or if I'm totally out in left field.
Definitely, I approach everything, together, but always trying to put it in the clinical context. It's hard in the ICU because, as we all know, in the ICU we're being bombarded, multiple patients having different things, and sometimes it's easier just to say like, okay, yes, go ahead and do everything and like just get it up. But like, actually, the easier thing, even though we don't think about it, is like just go in, see the patient, review the medications with the nurse. Ask the nurse, has something happened recently? What has happened, and that will actually give you a lot of information about how to work up your patient uh, better or like more appropriately in a way.
I think that's a great perspective. Both you'll get more information faster and you'll be more parsimonious about your testing. Kind of doubling down on some testing questions. What are your thoughts on just some specific labs? Like, do you always do a CBC with diff, for example?
As an ID doctor, yes.
I
I mean,
figured you'd say
I
that.
think it's just not complete. CBC alone doesn't tell me a lot. To me, at least, I want to know what's the neutrophil count. Is there any bandemia or not? Because even if you don't have leukocytosis, if you have bandemia, for me, it's significant.
Yep.
Uh, Eosinophilia, for example, in a
Big
patient.
change.
Drug-induced eosinophilia is a big one, or like DRESS syndrome. We recently had a case of DRESS in the ICU, which was horrific. Patient passed away. And so all these things are, for me, very important. As an ID doctor, I'm very detail oriented, not as my other colleagues. I think after ICU, I became more generalized, but like, yeah, definitely be differential.
What about procalcitonin? Yay or nay?
Uh,
Ooh, good question.
I'm an A kind of guy for procalcitonin. I mean, the main reason why I use procalcitonin is to, convince other doctors to stop the antibiotics. But it will never influence my decision about who needs antibiotics and what is the diagnosis. Sometimes there is a literature about filing abscess with procalcitonin levels. For example, you have a liver abscess, and if once procalcitonin normalizes, you might be able to stop antibiotics. Following things. I think everything in a trend is better. So for a trend, I think it can be useful, but to making your diagnosis an ICU patient, I think you will miss a couple of patients. I know you never should never base your decision on procalcitonin to initiate or make a diagnosis in an ICU patient. It's just not really something that I will do. Yeah,
Love it.
I mean, but I am assuming that you make all of your decisions based on the CRP.
And the ESR.
as an ID doctor, of course, yeah, all the time. No CRP, no antibiotics.
That's right. There you go.
I'm just joking though.
Yeah, before everyone like keels over listening to this.
Yeah.
The highly specific and highly sensitive CRP is
I think it's all
yeah.
about a trend. So CRP, ESR, great. Like, following like an abscess or a chronic infection like osteomyelitis, great. In an ICU patient, uh, I don't think it's gonna help you a lot unless you're doing some rheumatological workup, like temporal arteritis or something on that realm. In a way, I would say.
We'll talk to Room about it, see if they like it. I think nobody likes it at this point.
Yeah, Rome maybe will like it. I don't know.
All right, we've covered a lot of great stuff here on the general approach to fever. Any other final pearls for the general ICU patient with fever?
Any final pairs? I mean, history and physical. History and physical. Talk to the family. Talk to whoever was in the room or with the patient. Ask them what their normal status is and what's happening now. I will say, and that will tell you most of the things. If the patient was in the hospital while the developed fever, so hospital acquired fevers, then talk to your nursing staff for sure. It will give you a lot of information as well. You'll be surprised how much you can get just by talking to the nurse as
Right.
well.
Either make sure you have seen the back of your patient or talk to somebody who has,
I
because
will say see the back of your patient all the time, but also talk to the nurse because even if you see the back of your patient, the nurses have a different eyes. It's just a different set of skills, and they will tell you things that you might miss or not think about.
Awesome. All right, so we've laid down a great foundation for fever in the ICU. Now I think it'd be a reasonable time to start transitioning our discussion towards that returning traveler. Nick, I think in preparation for this episode, you did a little bit of digging and found some interesting facts. You care to share?
yeah, so I was surprised just how common illness is in the returning traveler. Per the CDC Yellow Book, which is a great resource, quote, as many as 43 to 79% of travelers to low and middle income countries become ill during or after travel.
Just go to Europe, you'll be fine.
Yeah, that's right. Go to a high income country. Another study I found reported that up to 19% of travelers in the developing world will have fever upon their return or within a few weeks. And obviously, not all of these people are, ending up in the ICU, but I was just surprised like what the baseline rate of illness after travel is.
So it depends where you go, in what exposures you have. But yeah, it's definitely common. We don't see it in the ICU because most of the things that the patients develop, they don't even seek medical attention for. Respiratory illnesses, which is the most common thing. Like it's not even reported, right? You go, you get the snuffles, and that's fine. Travelers diarrhea with a little bit of fever, no big deal. Will never see that patient. Most patients that go to like developing countries are more adventurous or is family visiting families and relatives. So this is not really what we see in the ICU, but yeah, it's extremely common. Now the fever in the ICU in a returning traveler, that's not that common. It's not definitely as common as the other things, but it's definitely what is clinically important. Let's put it that way, because these are the things that will kill our patients. And unfortunately, I seen horrible stories during my career as an ID doctor, internal medicine doctor in ICU, where the patient returns from the country they came from and develop fevers. The providers don't think about that key clinical piece, which is where do you come from, and because of that, they don't pick up the diagnosis. I don't know if you guys remember, but like during the Ebola outbreak, right? I even remember in Texas, a hospital turned away the first person that was diagnosed with Ebola in the U.S., and then the patient came back. I don't know if he dies or not, but like not thinking about it is the most common mistake. It's not about being an expert in tropical diseases. It's not about being an expert in ID. It's about, oh, this patient has a fever. This patient traveled 3 weeks ago, 2 weeks ago. Have we asked the patient if they traveled? Most of the time, the patient will not disclose, hey, I have a fever and I came from Kenya 2 weeks ago. They will just tell you, I have a fever, period. That's about it.
Let's double click on a couple of things you said there. So, I mean, I heard you say very clearly that, there needs to be sort of a screening question. Have you traveled recently? And maybe not just ask it once, but ask it multiple times, potentially of multiple people, in order to make sure you got the full answer, right?
Exactly.
Recently could mean something very different to one person than another.
And I think that the other thing too that I'm hearing from this is like kind of almost self-evident, but it's not really reasonable to expect your patient to know what's clinically relevant. If you don't ask the question specifically, perhaps repeatedly, using your own skill set and your background to sort of like do the digging, they're not necessarily going to know what to volunteer.
Exactly, exactly. So, I mean, and it depends on the clinical context, right? Like, a fever in a traveler can be even 6 months to years. A patient can develop a disease. Let me give you an example: rabies. Rabies, the latency period for rabies can be even 10 years. So, like, you don't know if this fever can be associated or not, like, unless you ask and you put it on your differential diagnosis. So how long ago? It depends on you, the provider, and it depends on your differential diagnosis. If a patient presents with encephalitis or meningitis to the ICU or altered status, a travel history can be relevant even 10 years ago. If the patient presents with hemolytic anemia in a traveler, even 2 years ago for some types of malaria can be significant. So, it depends. It all depends. So always keep it on the back of your mind. Always ask that question, regardless.
I saw one sort of framework that I liked. Think why this person from this place is developing these symptoms at this time. And I think,
Exactly.
kind of to your points, there's kind of different ways to slice it. What are the characteristics of the person? What are the characteristics of where they went and what they did there, importantly? What symptoms are they having other than fever? And then what's the timing? And we could probably double click on each of those: person, place, symptoms, time.
And I think we should like also categorize things. So we're now entered the realm of fevers in a returning traveler, right? So there are two types of returning travelers. So the good old person that from the United States that went and wanted to do a safari in Africa, wanted to visit the Amazon in Peru or Brazil. That's a different person that the person like me. I'm a migrant. I came to the United States from Dominican Republic, and I go visit my grandmother in a rural area in Dominican Republic. So I'm visiting families and relatives of BFRs. So those are two different group of people, and it's because the exposures might be very different.
Any particular activities you always ask about, or things that like are kind of red flags for you?
Definitely. So it depends on the clinical syndrome. So it depends what I'm thinking. So first of all, vector exposure is a big important one. Were you bitten by mosquitoes, tick bites, midgets, anything like that that happened to you during your travel? That's one thing. So exposure to different vectors is very important. Flies, etc. Also, what did the patient eat while they were there? So was the patient in India or Nepal eating everything and everything? So if you come from Nepal, you have 1 in 500 chances of getting, typhoid fever and enteric fever. So it's very highly likely that you likely have that. But if you were like always frying your food and everything, maybe less, but still possible, right? So those things are very important. Where do you stay? Do you stay in a hotel with air conditioning and you never had, any exposure to outdoor activities, or you were camping in the rural areas of the Amazon? So all those things, will point me towards a different scenario. Also, sick contacts. Where you were staying, where did anybody else was sick? Also, from your travel companions, how many of you got sick? So
Mm.
those things will tell me. And what was the clinical symptom that they developed as well? Were you also exposed to any wild animals? I have to know. I remember a case of a lady that she was in India somewhere, and she was petting this dog, and the dog bite her, but like they said, like it's nothing, whatever, no big deal. 2 months later, the patient presents with encephalitis.
Oh
Nobody
no.
knows what's going on. 2 months later, right? Nobody thought about it. Like it was 2 months later. So like, and then when you get the history, the patient, was bitten by a dog in India 2 months ago. So hence eureka right there. And the patient had, died, was diagnosed post-mortem. But like, those things,
And that was rabies, just to be clear for
yeah,
our
it was
listeners. Yeah.
rabies. Yeah. So it depends. Another patient from Haiti, that came with severe hepatitis to our ICU and was exported to livestock. And hence he had Q fever, diagnosed by
Mm.
liver biopsy and serology. So all these things: when, how, where, which exposures you had, who you were staying with, who else developed symptoms. All these questions are very important. It takes time, unfortunately, to dig into this. And unfortunately for our field, critical care medicine, it's harder because we don't have the luxury of time, and we don't have the luxury of having a patient with most of the time is conscious, or is not willing to engage in a conversation when you're high flow oxygen or intubated.
Right, exactly. I was reading on the CDC's website, they're like, ask about activities such as cave exploration, dental or
Exactly.
medical care, illicit sexual activity, or newly acquired tattoos. Like, yes, I just
Yeah.
got back from spelunking, having sex with prostitutes, and I got some teeth filled while I was there.
Yeah. So I mean, you'd be surprised what people do. Also, you'd be surprised what people do while traveling. So also keep the patient privacy. Do not ask questions from people, because our behavior while traveling might be different than the behavior that we have at home. So
Great point.
sex
Mm.
tourism is a thing for sure. Also, plastic surgeries in foreign countries is another thing. I had patients who had developed severe skin soft tissue infections. I never forgot this lady. She went, actually, unfortunately, Dominican Republic, and she had Brazilian butt lift or whatever
Mm,
that's called, and not a plastic surgeon, but she has come to the hospital 3 times with a skin and soft tissue infection, and she turned out to have a mycobacterial infection and
mm,
fortuitous infection. That the treatment is completely different. It can last 6 months to a year, and it's 4 different antibiotics. So, like,
Oh,
if you
geez,
don't
yeah.
pick that up or don't think about it, at the end, surgery call us for a consultation after a third time in the hospital. And it's like, oh, where you come from, Dominican Republic? I know. I mean, I come from there. I know what So being alert and understanding where the patient comes from is very important to understand what can you patient have.
right. So
Man,
so let's actually
that's
double click
yeah.
on that next. So let's talk about certain like regions of the world and kind of what you think as an ID doc.
All right, that's interesting. Like, so regions of the world, for example, let's start all the way to the east. Let's go to Southeast Asia, for example. So patient comes from Southeast Asia. I'm thinking about salmonella, for example. I'm thinking about malaria. I'm thinking about melioidosis. I'm thinking about scrub typhus. Thinking about hepatitis A or E. Each and every country is different. And not only each and every country is different, is where in the country are you staying and what are you
Mm,
doing in that country. So it's not like if you go to, the capital in Mumbai, in India, well, maybe nothing happened. But if you go and stay in the more rural areas and you get exposed to other things, and yes, the same thing with melioidosis, which causes severe abscesses everywhere in the body. Were you farming? What were you doing there? Were you spraying? Were you volunteering? Or were you just in a luxury hotel? Another thing, Japanese encephalitis. But like for you to get Japanese encephalitis is it's a very low chance, 1 in a million or something like that. So, but it depends of what were you doing, how adventurous you are. Then let's go to Africa, and all the bets are off, right? In Africa as well. You can have malaria is the biggest one. We know that for sure, and you always have to think about it. In a patient that comes from Africa with fevers or without fevers, patient comes ill to your ICU from Africa, your first answer is malaria. Your second answer is malaria. Your third answer is malaria. And likely the fourth is malaria. So, thinking about this is very important. Then enteric causes of fever, enteric typhoid fever, etc. All the rickettsial diseases, all the viral hemorrhagic fevers, dengue, chikungunya, etc., Zika virus, Lassa fever. There's so many. The differential is very broad, though. You know, just to make the public or the audience dealing some comfort, these cause of fevers are, not as common. Like the viral hemorrhagic fevers, like Ebola or Marburg virus, are not that common. So do not think that every patient that comes to your ICU will have Lassa fever, but just keep it on the back of your mind and keep it there. Another thing that you have to also think about is like if you think the patient has an infectious cause of fever that is highly transmissible, it is better to isolate the patient early than finding out later, oh, my patient had this and this thing and I didn't isolate it. So keep that also in the back of your mind. If you think the patient has meningitis, you do drop isolation and until you rule it out, it's okay. Then going to Latin America. So Latin America is a very it's a very different very different depends on the region. Is it Central America? Is it North America, Mexico, for example, or is it South America or the Caribbean?
mm.
So if you're coming from South America, including Brazil, Peru, Colombia, the northern part of Argentina, You have to think about what different diseases. You have to think about yellow fever for sure. And they actually declare, they're having an issue with that right now as well. Dengue fever, if you're coming from the Caribbean region of Latin America, Zika virus as well. Malaria, but malaria in Latin America, thankfully, in Latin America, we have mostly Vivax malaria, not falciparum malaria, and we'll talk about that later. But Vivax malaria is less likely to land you in an ICU
Mm.
than falciparum malaria. And then you have to think about rickettsial syndromes as well. And the list goes on and on. We also have hemorrhagic fever viruses in Argentina and Bolivia. We have now, it's very in vogue. I don't think it's going to land you in the ICU, but the Oropuche virus is another, kind of, is an arenavirus that can mimic dengue or chikungunya. So, there's a lot of things to think about. What I will say for the ICU audience is what can kill my patient and what cannot kill my patient. And that's the way I, rule out things.
Mm.
What can kill my patient is malaria, is dengue, is enteric fever, is tuberculosis, yellow fever. Those things can kill my patient. Also, hantavirus and hemorrhagic fever viruses can kill my patient, but I have no treatment for it most of the time. But I can at least do good supportive care in the ICU.
And ECMO.
Yeah. And also isolate the patient to protect your
Right.
staff as well. So that's the way I think about things.
So we've covered a lot of potential diseases and associations here. We're going to have this all on our website too. But what is your go-to reference for this? Like if somebody tells you they came from a country that you don't have this encyclopedic knowledge for, like where do you go to see like what's there?
Yeah, good question though. Definitely, and it's something that even I wouldn't call myself an expert, but yeah, I have done a lot of studies on tropical diseases and infectious diseases. But I always, no matter how much I know, I go to these websites, the WHO, to look for any outbreaks that are currently happening, where my patient came from. I go to the CDC. The Yellow Book is a great reference, and you can go to the online version of the Yellow Book. That way, it's up to date. GeoSentinel, which is geosentinel.org, is a organization of all the travel medicine clinics in the U.S. So they upload information about where the patients are coming from and what alerts you have to think about, and so you can have a reference of what's happening currently. It's like you guys remember the living guidelines of COVID. The same thing with this approach with fevers. I will always recommend, no matter how expert you are, to always go ahead and if the patient tells you I came from Vietnam, go and see what's happening in Vietnam, especially in the region where the patient came from. So, for example, India a few years ago had an outbreak of Nipah virus, which is a virus that can cause severe encephalitis. If you don't look at in Kerala, in the south of India, this is happening and your patient came from there, you're not going to think about it because you never see Nipah virus, right, in the United States. And not only in the United States, not only like outside, like think about, is the patient coming from Minnesota? Is the patient coming from Maine in the East Coast and now coming here? You have to think about all the diseases, right? Like so if he's in the East Coast and the patient you're from the West Coast, what's going on in the East Coast? So is babesiosis possible? Anaplasmosis possible? So the country by itself is huge, and the epidemiology in our own country is extremely broad depending where the patient comes from. And you have to think about keep an open mind and a curious mind. And and if you are lost, ask your ID colleagues for questions for advice as well. Yeah.
I think it goes without saying that if I'm looking at the CDC Yellow Book for like outbreaks of Nipah virus, my very next phone call is going to be to ID.
Okay, all right. We appreciate that.
Okay, so we've recorded for about an hour now. We've talked about some really great fundamental concepts with respect to fever, the returning traveler. I think now maybe we can start to get into some cases. Nick, do you have a case we can maybe start off with and see what Luis does with this one?
I've got a good one. All right. So you have a 24-year-old woman who presents with cyclical fevers every 48 hours associated with chills and drenching sweats, headache, and confusion. She just returned from a backpacking trip through rural Uganda 1 week ago. Vital signs reveal high-grade fever and tachycardia. Her basic labs in the ED reveal anemia, thrombocytopenia, and mild acute kidney injury. So what's going through your head right now? Is it malaria?
Actually, yeah, malaria, but a lot of things are going through my head. I mean, she's 24. She's very sick, appears to be. She's having thrombocytopenia. You mentioned leukopenia as well, right?
Yeah.
and renal failure. So that tells me that, a 24-year-old lady should have a huge physiological reserve. And the fact that she's presenting with all these symptoms is very alarming to me. I first will ask her if she can communicate with me. Is her immunization status? Did she get any vaccines or pre-travel advice before she went to this camping trip? And if she was taking any prophylaxis while she was there, for example, malaria prophylaxis or something on that realm as well. I will ask her if she has any medical conditions. First of all, did she take any medications at all? I will ask her about what was her exposure and how long did she stay in that place? Where was she staying? And what did she do besides camping? I assume this lady is landing in my ICU now. Is that what it is?
Yeah, let's say that she's coming to your ICU because she's sick. They're starting pressors because she's a little hypotensive.
Yeah. So, in that case, I don't have a lot of time to wait. And I will definitely, the first thing that I will do is do the basic labs, but also do a peripheral smear and try to rule out malaria. And if it's 2 a.m. in the morning, I will try to do it myself. I will call them at the lab tech and tell them, like, can you do please a peripheral smear for me that I can go and take a look at the lab? Even anybody, that has a YouTube video and can pull out like slides. If you see an erythrocyte, we all did it in medical school. We don't think we can do it, but actually we can. Just take a look at the smear. If you see something weird in that smear, then you might think just hit it by there just by doing that. The first time I diagnosed malaria when I was an attending, I was in the middle of the night in a hospital in Delaware all on my own, and I went to the lab and did it. And actually, the patient told me I think I have malaria. Funny enough, like he came from Africa. He told me, and like sure enough, he had malaria. So sometimes, the patient can tell you more than what you think they know, and they are aware of these things as well. So I will do that. I will, examine the patient very well. Does the patient have any rash in the skin at all, or no?
Let's say no rash.
No rash. Okay, so if the patient had a rash, for example, I will think also about dengue as well. But usually when the patient is critically ill, the patient doesn't have a fever anymore. So usually a patient with dengue that presents with a critical illness, it happens after the fever has gone down. So that will be lowering my differential as well. Do we have liver enzymes on her at all?
Let's say that they're elevated slightly. Yes.
They're elevated. Is it cholestatic pattern or is just hepatocellular pattern? What is it?
Let's say it's a hepatocellular. Yeah.
Yeah. So
you're stretching my ability to create a case here.
No. The thing is, like, I'm thinking about different things. If the patient has more a cholestatic pattern, I will start thinking about Q fever or start thinking about leptospirosis. If the patient has more hepatocellular pattern, then I'm thinking about dengue virus or maybe even malaria as well. So it depends on what the patient has. Also, rickettsial diseases can also present this way as well. But yeah, my first differential with malaria or malaria with concomitant another bacteremic infection or other bacterial infection as well. If she had any respiratory symptoms or GI symptoms, I will start thinking also about typhoid fever as well. Though the presentation is usually the incubation period is usually a little bit longer. Another thing that we have mentioned is that we also have to think about the incubation period when the patient presented. So ask the patient how long they stay there, and ask the patient how long have you been sick? Not with fevers, for how long do you start feeling sick? And that will tell you, from where to where, because most of the times the patient starts feeling sick at the end of their trip. If it was at the beginning of the trip, then this less likely to be, an associated travel, but it's something that she acquired before she got to the travel. Versus I started feeling sick 3 days before I came to the US. I was camping, everything was well, and then boom, all of a sudden I got sick. And what were the presenting symptoms? Was it myalgia? Was it conjunctival diffusion? Was it just muscle ache? Was it fever? Do you take your temperature or not? All these things really matter to make a diagnosis. So I will start blood cultures, peripheral smear, my full blown test, and then targeting about what the patient is complaining. Is the patient complaining of abdominal pain or that or whatever, things like that.
So Nick, what do those blood smears look like?
Let's say that we've got Plasmodium falciparum with high parasitemia.
Oh wow. Okay. So high parasitemia. So one thing that I would like to know is my patient visiting family and relatives, or is this patient completely immune naive? So it's very different to have a patient with malaria that they are actually living Kenya and they are here, for whatever business, visiting family, but they usually live in that environment where malaria is present. So they have what is called premonition. So premonition means that the patient has a partial immunity to malaria, and we don't see severe cases. The fact that I'm seeing a severe cases in this patient is very sick tells me that she likely is either naive to malaria, she's never been exposed to malaria, or she thought she was immune to malaria because she lived in whatever place in Africa for many years, but now came to the US and lives here for the last 40 years. And they take less risks. They take more risk because of that. So, depending on what it is, that will also tell me one thing. Because, for example, it's very different to see this patient in Africa than seeing it here. If the patient was an African patient that is always exposed to malaria, you have to think about like a lot of people will have malaria parasites in the smear. It doesn't mean that it's malaria causing the disease that you're seeing.
Great point.
Whereas somebody in Seattle with falciparum in their blood, it's probably malaria.
Yeah, it's definitely malaria, right? So we have to also ask yourself that question. Be cognizant of like, is this patient a local from that place? Or is this patient actually completely foreign that doesn't have any immunity whatsoever? If she doesn't have any immunity to malaria and she's a good old American patient that just went to do a trip there, then you have to be very, very alarmed about this finding. So a parasitemia level above 5% in a non-immune patient is alarming. In an immune patient, we more than 10%. But what's more alarming to me is about her clinical presentation. She's in shock. So just by the definition of shock, she definitely has severe malaria, and you have to act fast. And the reason you have to act fast is because the exponential reproduction of the parasite in the blood is extremely fast in falciparum malaria. It's good to mention also that there is another malaria that behaves this way as well. It's called Plasmodium knowlesi malaria, which is a zoonotic malaria that comes from Southeast Asia. So either if you see Plasmodium falciparum malaria, or you see something that looks like Plasmodium malaria, but is presenting as a severe malaria, so those two parasites can kill the patient. In severe malaria, the treatment of choice is artesunate, and the reason is because of the fast killing rate that this medication has. The dose is 2.4 milligrams per kg, but the problem is that a course of artesunate for 24 hours can cost you around $35,000. So not all hospitals stock artesunate. So you might be in the middle of the night, and like if you're in a good old community hospital somewhere in Ohio, you might not have the artesunate with you, and that's a problem. So every time I walk into a new hospital that I'm going to work in, I ask, what's the deal with the artesunate? Where can I find it? I will cover this patient also empirically for, bacterial infections until I figure out enough what's going on, maybe with ceftriaxone or dosing, whatever, your beta-lactam of your choice, until I really, really rule out any other infection as well. And also keeping on the back of my mind also rickettsial diseases as well.
So let me give the follow-up here. Treat with IV artesunate, mental status improves within about 2 days. Parasitemia clears in about 3 days, and then she makes a full recovery.
Okay. So, a caveat with artesunate is like, because it's too expensive, very expensive, right? You give it zero, you give it for 24 hours in 3 doses, but you always follow the parasitemia load. Once your parasitemia load is less than 1%, then and the patient is able to swallow and, take anything by mouth, you can transition the patient to oral therapy with, Coartem or artemethyl lumefantrine to complete the 7-day course, or you can do any other,
And if you don't, I bet you your chief of pharmacy will be breathing down your back. So
yeah, but
Right.
so you don't have to keep it completely, but once you get the patient out of the severe kind of malaria and the patient can take PO, then of course you can take the patient out of the IV therapy. Always follow the parasite percentage, and the reason is like your patient parasitemia load should be decreasing significantly in the first 24 hours. And if it's not decreasing, then you might be dealing with something resistant. It's not a big concern, but it's definitely a concern in Southeast Asia in some degree. So, especially with counterfeit medications, the parasite has become resistant. So it's a good idea always to follow the parasitemia load and make sure that your trend is going down. If your trend is not going down, or like not going down fast enough, just keep that on the back of your mind. I hope that nobody has to encounter that, but it's something that you might encounter that you have to think about.
In the interest of keeping this train rolling down the tracks, I want to try to move on to maybe another case, but just before I do, Luis, any other pearls on malaria specifically that our listeners really need to hear?
Yeah. So, the things like I always, hear about like experimental therapy for malaria, and like when the patient is dying in our ICU, we want to save the patient, but like things that we know that don't work in malaria, steroids, they don't work. And plasma exchange transfusion, they don't work. So even though somebody brings it up, they have done multiple clinical trials on it. It doesn't really work. Be careful with the fluids as well, because also like giving the patient a lot of fluids can throw the patient into pulmonary edema, and that can be a problem in malaria. So in our ICU, make sure that we have the technology that other countries don't have. So like malaria in Africa is very different than malaria in the United States. You can do a lot more for the patient here. You can do an ultrasound of the lungs and see if you're actually floating your patient in shock. So that's very important, because one of the most common complications of that can land the patient in the ICU and kill it is pulmonary edema. So that's one thing that you have to think about. If the patient has altered status, also make sure that you rule out CNS infections as well, because they can have meningitis and malaria at the same time. So patient with prostration and severe malaria, it's a good idea to do an LP. Make sure you rule that out as well, and then also be make sure that don't dilly dally on the medication. You need that medication. You need it now, no matter what they tell you. Is your patient in the ICU and your diagnosis of malaria is artesunate? Artesunate. If you cannot find artesunate, then quinine and clindamycin together. The thing is, I haven't seen quinine in 10 years in the United States. So I don't think you'll be able to find it. And so
is there something that you can substitute quinidine instead? Is that a thing?
quinidine you can, but like also it's not available anymore. So I mean, you can talk to your pharmacy. Maybe somebody stocked it, but I be
You're gonna be sending somebody out to buy tonic water.
I was going to say tonic water. Just flood it with tonic
no,
water.
please no. You have to drink a lot of tonic water if you want to treat malaria with that. You might kill the patient for hyponatremia.
Oh,
So no. So yes, just be diligent about it. Yeah. Just don't really lose time with a patient. Yeah.
All right.
Great
wow.
points.
Okay. Well, yeah, incredible points. Let's move on. As much as I would love to spend another couple hours talking malaria, I think we probably have a few other cases to hit. Okay. So here we've got a 32-year-old gentleman who's presenting with a 3-day history of high fevers, severe muscle and joint pain, headache, and this person has a diffuse macular papular rash. He's also got some gum bleeding and some easy bruising. And on history, he does note a return from a 2-week trip to Brazil about 5 days ago. When you get some labs, you're seeing leukopenia, thrombocytopenia, and elevated liver enzymes. So what would be maybe the top items, Luis, on your differential for a presentation like this? And then we'll give you some more data.
And how old is this patient?
32.
32. So he's a young patient that comes in from Brazil with rash, fever, leukopenia, and hemorrhagic symptoms in a way. I wish all the patients would present like this, right? Like a very classic presentation, I would say, for dengue fever. But you have to consider other things. A 32-year-old man with this condition, I will also think about acute HIV infection as part of my differential. Very, 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 very concerning for that as well. I will think about other arboviruses like chikungunya virus or Zika virus and other Pusha virus. So those things also, I will keep it on my differential as well. Those will be my top 5 differentials, but I will also consider like other things like, once again, enteric fever as well as part of my differential.
Awesome. Okay.
Yeah.
I love that. So, being the astute clinicians that we are and having excellent ID consultant, we begin our workup and come to find out they do have a positive NS1 antigen test confirming that they've got dengue virus infection. They also got a positive tourniquet test, and you do your whole workup. There's no evidence of bacterial co-infection, and on this particular patient, there's no evidence of malaria on your peripheral smears. So, what do we do with that?
Well, I will still consider like acute HIV infection and do my test, like do other things, ask about other exposures as well. Yes, I made a diagnosis. It doesn't mean that this is the only thing happening. One point why, like I'm very curious about is like in dengue fever, the critical phase. So we have initial illness, right, with fevers. It starts like approximately 4 to 7 days of that, a fever, high fever, muscle aches, everything else. And then there is a deference period. And in that when the fever breaks is when you have the critical phase of dengue, and we call that a plasma leakage syndrome. So that's when the endothelial cells get damaged, and you can have leakage of plasma in the body cavities, and that's where you start seeing the complications of dengue. You start seeing the severe thrombocytopenia, so the platelets can go down below 100,000, almost 30,000 in below. You can have also leukopenia at that time, and you can have also what is called hemoconcentration. So because you're leaking your plasma, then the blood gets hemoconcentrated. So the patient gets intravascularly dehydrated. It doesn't mean that they don't have volume. They have ascites, they have pleural effusions, they have all these things, but intravascularly, they just cannot keep that volume in. And in that phase, that can last, 48 hours, 72 hours, that's when your patient is going to need ICU care, and is when your patient can once again die from dengue. Also, you have to think about that dengue is a virus that can, yes, indeed, can cause this classical presentation of fevers, muscle ache, yada, yada, yada. In the ICU, the presentation is different, right? So the patients that you're going to see with dengue in the ICU are the patients who develop encephalitis, myocarditis, severe pulmonary distress syndrome, and pleural effusions, severe ascites, and also severe bleeding. So when your patient is going to be in the ICU, I assume it's going to be on your critical phase. And in the critical phase is when you have to be the treatment for dengue in that phase is about high clinical suspicion and good supportive care. And what I mean by that is that you have to, hour by the hour, you have to take a look at the urine output of that patient. You have to focus that patient all the time to see where they're accumulating fluids. If you see a patient with pleural effusion and dengue, it's very different than a patient without pleural effusion. If you see a patient with ascites and dengue, it's very different. Why? Because the prognosis is very different. They can also develop severe myocarditis. So they can go into what is called cardiogenic shock as well. And there are cases also of severe encephalitis as well. So is this patient also developing another CNS infection? It's all due to dengue as well. So patient comes into the ICU. First of all, what you're going to do is assess the fluid status of that patient. And if the patient is that patient that you're telling me right now has systemic symptoms and warning signs, right? Tourniquet positive, bleeding through the gums, thrombocytopenia.
Actually, can we pause for a second? What is the tourniquet sign? What is that?
So the tourniquet sign that we don't see here, but it's like because the patient has severe thrombocytopenia, when you put a tourniquet on them, it can create what is called I'll say petechiae around the tourniquet. So that which speaks about platelet dysfunction is what we talk about tourniquet sign. Is it something important in the US? I don't think so. Why? Because we have CBCs here. We just
Right.
we're gonna see that, and we'll see thrombocytopenia. When I was a medical student in Dominican Republic, and I thought dengue was the most boring disease of all time because that's what we saw every single day. Now I came to, and when I came to the US, I was like, oh, this is so interesting. Yeah, that we will do that to screen the patients for platelet dysfunction, thrombocytopenia. But here you have a patient that clearly has thrombocytopenia. How low it is, it depends, right? It will start getting lower and lower as you get into the critical phase. But I think
And are we transfusing these people?
good question. So that would what transfusion you're talking about? You're talking about platelet transfusions, or you're talking about no? So we're not doing that. So studies have shown that giving platelets to patients with dengue really don't alter the outcome of those patients. Their thresholds, like if the patient has a platelet count of less than 10,000 and the patient is actively bleeding, yeah, you're gonna give him some platelets, of course. But the patient of a platelet of 30,000, 50,000, 20,000, no, you don't have to give those patients platelets. Though you have to transfuse the patients that are actively bleeding. So what you do, first of all, is assess the patient fluid status and the hemodynamics. So pulse pressure. The best guidelines that I can tell you is reading the WHO guidelines. Last time they were updated was in 2009. But it gives you a good algorithm on how to treat the patient with dengue. First of all, you assess the patient. Is my patient hypotensive or has a pulse pressure above 20? So, and that's those patients that has they have hypotension. You give them fluids. Initially, you have to be careful with the fluids because we talk about that the patient has a capillary leakage syndrome. So if you give them a lot of fluids, it's a Goldilocks kind of situation. So, right? So if you give them a lot of fluids, you can float the patient up, and you might have to intubate. And if you give them too few fluids, then there's a problem because they remain hypotensive. So they talk about giving them 20 ml per kg as a bolus and reassess the patient and see where you are. And also monitor the hematocrit every 4 to 6 hours. So you want to follow the hematocrit. Is the hematocrit going up? Is the hematocrit staying the same, or is it going down? You're going to monitor also the urine output. Is my urine output 1 ml per kg per hour, or less than that. What's going on with those dynamics of the patient and capillary fill as well. If the patient doesn't respond to the first fluid bolus, you can repeat a second bolus and also assess the hematocrit while you give the bolus. If the patient is hemoconcentrating while you're giving the patient fluids, it's telling you one thing: the patient is losing the fluid that
Yeah,
you're giving them all
that's
the way
bad
to the
news.
third space, and so you might be getting into trouble, and you might be able to repeat those fluid boluses, being mindful that you might float the patient up. If the hematocrit stays the same or goes down, is your patient bleeding? So look for bleeding as well. So the fact that you have endothelial dysfunction, capillary leakage, and thrombocytopenia puts the patient on high risk of bleeding. So if your hematocrit is going down or staying the same while you're giving fluids, that's a bad sign, and you have to think about look for some kind of bleeding and transfuse. Don't wait until the hematocrit goes down to 20% on those patients. If the patient came with a hematocrit of 40 and you give them 5 liters or 4 liters or 3 liters of fluid and the hematocrit stays the same, it's going down, and your patient is hypotensive, that patient is likely bleeding. And you have to give the patient either whole blood or PRBCs depending on how much fluid can the patient afford. You have to think about that. So doing hematocrit every 4 to 6 hours, reassessing every time you give fluids, and also giving fluids mindfully, but always giving fluids, it's important. The guidelines say you give, boluses of 20 ml per kg or 10 ml per kg, and then you can use colloids. Theoretically, they might stay longer in the body. Like, well, do we know that? I don't know. I'm not gonna defend one position or another. That's the ICU care 101. And then if the patient is getting better, you give the bolus, the patient's blood pressure is improving. You started pressors, but the pressure's coming down, the hematocrit is staying the same or going higher, whatever, and your urine output is good, then you're in a good space, and you can start reducing those fluids. So you can go from 10 ml per kg per hour to 7 ml per kg per hour, and then keep the patient at 1 to 3 ml per kg per hour until the severe phase the patient goes through the severe phase. That should last 48 hours, at least, and that's about it. Once you get through the patient to those critical 48 hours, you'll start seeing recovery. So you start seeing the platelets coming up, the leukocyte counts coming up, and the fluid that was accumulated in the abdomen, in the pleura, etc., will start getting reabsorbed. Unfortunately, some patients do develop, pulmonary edema, and you might have to, intubate them, putting on, CRT for a moment, whatever. But that's a minority. Most patients, you can write them out and do that. Though there are some severe complications of dengue, so the patient can develop myocarditis, and then you're in a big, big problem right there. So
Yeah, putting somebody on mechanical circulatory support when their platelets are 10 is not one of my favorite things to do.
not a favorite thing of anyone, right? So you might support the patient with good old cardiac shock, therapies, the vitamin, whatever. You have to assess case by case. This is the minority of the cases. The problem is that in dengue, and as an intensivist, that's what you're going to do. Clinical pearls is, first of all, be mindful with the fluids. The patient will need fluids. You have to reassess every time you give boluses, get a hematocrit, and see what's going on. Is the hematocrit going up? Is it going down? It's staying the same. Monitor your urine output. You can give fluids, but don't go bananas with the fluids either. It's not like you have a septic patient that you can flood them with fluids, because that fluid is going to go somewhere else, and then you have to deal with it, and that's the problem. Another pearl is that in this scenario, maybe steroids is not your best allied. And why is that? Because you already have thrombocytopenia, and the patient is very, very, very prone to bleed. So if the patient has a stress gastropathy and a platelet of 10,000, 5,000, the likelihood this patient is going to bleed through the abdomen is very high. Also, keep your eyes out for bleeding. If the patient hematocrit staying the same or going down while patient has dengue and thrombocytopenia, transfuse the patient. Do not wait until that hematocrit goes down, 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 and look for bleeding somewhere. Can it be controlled or not? In the third, where dengue occurs, which is the third world countries, the developing countries, let's put it that way, to be more politically correct. You might not have the access to all these things, but here you might look for other alternatives. So, the guidelines really show are targeted not to the developed countries, but to developing countries of how to manage dengue better. So initially, start with boluses, reassess hematocrit, and be mindful. And you can repeat this 2 times. think about colloid maybe if you can. That might help you out. The evidence behind it, whatever. And then
We could have a whole episode about that.
yeah, exactly. And then supportive therapy. And also platelets do not work. So don't worry about the platelets. The platelets are going to go down. Don't get too scared. Just brace yourself right there. It's okay. If it's below 10,000, you can consider, transfusion of platelets. And if not, then you just have to wait it out and see what happens. The reason why the patient develops thrombocytopenia is multifactorial. They talk about bone marrow dysfunction. They talk about autoimmune destruction of the platelets. So, a lot of different factors. Actually, there is a way to know when your patient is getting better from your critical phase is looking at their smear and seeing if there is immature platelets in the smear. And if you see immature platelets in the smear, you see that, okay, the bone marrow is recovering and like, we're getting through this. So most patients will recover just with good supportive care. Some patients, unfortunately, there's nothing you can do about it and, are going to pass away, especially if you're elderly or have a low immune status, etc.
Great. Okay. Perfect summary. In the interest of time, let's do a couple more, but maybe I'll try to make them a little shorter, a little faster.
Like rapid, semi-rapid fire.
Yeah, semi-rapid fire. Yeah, because I want to cover the breadth. All right. So here's another one.
Okay.
So a 29-year-old man presents with a 10-day history of fever, abdominal discomfort, and a faint salmon-colored rash on his trunk. He recently returned from a month-long volunteer trip in rural India where sanitation was, quote, poor.
Okay.
What are your initial concerns? What is your approach to this gentleman?
So you have another syndrome here. So it's fever and also GI symptoms, right?
Right.
So fever, GI symptoms in a patient that just came from India. So that's screaming salmonella typhi or enteric fever kind of etiology. The classic poster child for salmonella is Nepal or India all the time with good reason, right? Like you have a very high chance of developing that. So first of all, I will ask them when they start feeling sick to assess for in the incubation period, as usual, to actually understand if this is actually compatible with this. Think about other things that can cause a rash and fever and GI symptoms in a patient returning, which is once again dengue, Zika, chikungunya, and other viruses that are vector-borne diseases. Always ruling out malaria, as usual, no matter what it is. Malaria, and take it from there. In a patient that I'm thinking about typhoid fever, always blood cultures is very important. And if the patient has diarrhea, then a stool culture is very important as well. Thinking about also that typhoid fever can present with constipation in 30% of the patients. So even if the patient doesn't have diarrhea, if they have abdominal pain and a salmon color rash and all these things, they can also have salmonella as well. And thinking about complications of salmonella, we recently saw a patient in our ICU. Maybe I don't know if you were involved, but she had a salmonella aneurysm infection. So salmonella loves the blood vessels, can cause endocarditis. So looking for complications, mycotic aneurysms, septic arthritis, and other things is also very important to assess how long this patient needs to be treated, what are the risk factors, etc. And basically that.
And what I always find confusing is that salmonella is an eponym. It's named after a Dr. Salmon, but the salmon-colored rash is like the fish.
Yeah.
So it's like a good buzzword association, but I feel like I would never call something salmon colored unless I knew the diagnosis already. You know what I mean? It's like,
yeah.
Okay. So your blood cultures grow salmonella, enterica, serotype typhi.
Okay.
There's no evidence of malaria, rickettsial disease, or other infection. So what's treatment?
What's the treatment? So once again, it will depend on the patient, where the patient comes from. So this patient, you already told me, came from India. Even though India is not super high in like thinking about MDR or XDR salmonella, I always have to keep it on the back of the mind. So the treatment for salmonella usually can be anything from ceftriaxone 2 grams daily to you can do azithromycin as well. Before it was quinolones, but the quinolone resistance rates is very high, so I will not use it as empiric therapy. Other therapies you can have is Bactrim, but if the patient is bacteremic, I will not use that. But thinking about how sick is my patient, I will say the first thing, if the patient is very, very sick and I start the antibiotic, it's not getting better, I might pull out some other medications, but I will start with good old ceftriaxone, will be fine. It will be different if that patient if you tell me that patient came from Pakistan or Iraq. The patient came from Pakistan or Iraq, then I'm thinking about XDR salmonella. And the current guidelines recommend actually dual therapy with meropenem and azithromycin for those patients. If the patient is acutely ill and you think that the patient has a severe complication like mycotic aneurysm and you don't have susceptibilities, I wouldn't blame you for pulling out your meropenem and like until proving otherwise. If you're thinking about
Can I get that in writing? I feel like ID always blames me for
I will
the
say
meropenem.
it's a fact. Somebody patient like you tell me the patient has a mycotic aneurysm, salmonella. I will like septic
You let
shock.
it slide.
No, I will like let it slide for sure. If the patient is coming from Pakistan, Iraq for sure. Until proven otherwise, meropenem, maybe dual therapy, meropenem azithromycin. The evidence behind that, I'm not quite sure it exists, but it's just like you don't want to miss the boat on those patients. The treatment will depend on, the duration will depend on how bad is your disease. If does the patient has septic arthritis, does the patient has aneurysms, does the patient has, for example, endocarditis? What's going on with that patient? Did the patient has a perforation? For example, we know that salmonella enterica infections can lead to GI perforations and peritonitis. In that case, the fraction will not be enough, and you have to also cover for anaerobes because you have now secondary peritonitis.
Right.
So it will depend on all that, and always keeping on the back of your mind that salmonella is a pleiotropic spike bacteria that can do a lot of things. And depending on what it's doing and causing, you might have to treat it differently in a way. And think about MDR salmonella, XDR salmonella. What is it?
I have a bit of a confession to make here. So, like, in the EHR, when there's two patients in the unit who have a similar name and they pop up that name alert, I always have this sort of mental name alert when I'm thinking about typhoid versus typhus. Can you give us a sort of like,
Oh God.
compare and contrast on these two? Because I know they're both relevant.
They're both relevant. They both bacterial diseases. They both you can get from India. Actually, my first case of scrub typhus, I saw it in India in the CMC Christian Medical College of Vellore. So scrub typhus, which is a disease caused by bacteria with a very funny name called Orienta Tsutsugamushi. I can't pronounce it very well, but it's Tsutsugamushi Orienta. It's a rickettsial, I would say rickettsial disease that can cause fever, a rash, and multi-organ failure. When I think about Orienta Tsutsugamushi, I also think about anaplasmosis. I think about the Indian anaplasmosis in a way, but anaplasma doesn't have a scar. Orienta Tsutsugamushi does have a rash. So the way you diagnose scrub typhus is by looking at the patient with thrombocytopenia, leukopenia, multi-organ failure, and a scar. So the scar gives you the diagnosis, and it's very classical when you see that scar where the shigger actually bite you. It's the disease caused by shiggers, and the bite of a shigger. So that shigger bites you. 7 days later you start getting very, very sick. Treatment is with doxycycline. And it's similar to like other causes of like rickettsial-like illnesses. And then you have murine typhus, epidemic typhus from other causes of rickettsial diseases. Salmonella typhi, the name comes from Typhoid Mary, to like the bacteria. And there's a funny story about Typhoid Mary and how she was stigmatized in many ways. But that's another story, though. Does that answer your question?
Yeah. So I think typhoid is salmonella. Typhus is rickettsia. Typhoid is transmitted through water that's contaminated or food.
Or food, yeah.
Typhus is by the bite of chiggers, which, by the way, just Google that. They're terrifying looking. You don't want to get bitten by them. Clinically similar, but am I right to say that typhoid is going to give you more GI symptoms, and typhus is going to give you more of the bites, like you said, and systemic?
It's multisystemic diseases, more like leukopenia, thrombocytopenia, and like in the ICU would be multi-organ failure and everything else. And they both come from Southeast Asia. India definitely there on the Tsutsugamushi area. Let's put it that way. I will say very nail it right there. One is the other thing is like the treatment is different. One is doxycycline. So when you don't know what's going on with your patient, thrombocytopenia, throw the doxycycline. It's fine. It's okay. I think it's complete. Nobody's gonna blame you for that. When you have a patient with thrombocytopenia, multi-organ failure in the ICU, throw the doxy until proven otherwise. I wouldn't blame anybody for that. And then thinking about other things too. Yeah. Doxy is my favorite antibiotic of all time. So
excellent. I know that trick too. If you don't know what it is, doxy might be the answer.
Especially if there is
no one dies without doxy.
Thrombocytopenia is like for sure. Another thing about salmonella is in an ICU caveat though is that salmonella, severe typhoid fever in the ICU warrants steroids. So the paper that supported that is quite old. It's like 1984. So I don't know how relevant it is right now, but definitely on the guidelines, you can find dexamethasone. You throw like I believe it's like 6 milligrams once per kg once, and then like 3 milligrams every 6 hours for 48 hours. So you think about like in the ICU, your patient with typhoid fever, you might want to throw the
Mm.
steroids to them as a part of the as a point to decrease mortality on those patients. It's an ICU kind of thing that only you will know. I don't think a lot of ID doctors think about steroids when you think about salmonella, but if you're in
Mm.
the ICU, that's something you have to think about as well. Yeah.
Um, I feel like if I'm citing papers from the year I was born, people are going to look at me a little funny. But that's good to know.
So great discussion so far. I think in the interest of time, we'll try to cover one more case and maybe dovetail it a little bit with some of the other content we were hoping to hit on. So let's go with this 34-year-old man who's coming in with sudden onset high fever, chills, severe back pain, nausea, and jaundice. This gentleman came back from a rainforest expedition in the Amazon basin, and not really sure about vaccination status. Labs that you get show an elevated bili, elevated liver-associated enzymes. They're in the thousands. We've also got some thrombocytopenia and signs of coagulopathy. What is kind of high on your differential here?
Just to save time, his malaria is negative.
Okay, good. Good to know. I was gonna say, give him malaria. Well, you have a patient, severe illness, multi-organ failure, fevers, came from the Amazons. So of course we already rule out malaria, then thinking it's a syndrome of elevated liver enzymes and fevers in a patient that's returning from a travel trip. So my big differentials are yellow fever, of course. Leptospirosis is another big differential, whale syndrome depending on the incubation period. Also, Q fever can give you severe liver enzyme, like bilirubinemia in a way. So thinking about that, Oroja fever is a patient was on the Andean region, whatever, with Bartonella. Those are the things that I'm thinking about. Also, dengue can give you severe liver enzyme elevations. That will be lower in my differential because this is more bilirubin elevation than anything else in this case. But I will put the yellow fever first. I'll be surprised. The problem is like, is this patient immunized by yellow fever or not? And what is his immune status as well? Is this patient is it immunocompromised or is it immune competent?
As I recall, to travel to certain countries, you have to have that yellow piece of paper that
Exactly.
demonstrates your yellow fever status.
Yes, that's true. Like definitely in countries of like some countries in Africa and Middle East, they require you to have the yellow fever certificate. Some others don't. For example, you can get yellow fever in Peru and not really have the yellow fever certificate. I know because I went there and went to the Amazons and I didn't have the certificate. That was dumb. But yeah, it can happen. You can definitely be exposed in the Amazons. I've been twice, and yeah, I should get my vaccine myself. It's just like so hard to get in the United States, honestly. But yeah, I will think about that.
I remember getting it to go to Africa, and I had to like arrange in advance to have it available in the clinic.
And one thing is like now is life. Before it was every 10 years. Now it's lifelong. So once you got the yellow fever vaccine, you're fine. You're good to go. Another thing is that the vaccine itself can give the what's called yellow fever induced by the vaccine, especially if you're above 65 years old or immunocompromised. It's a life attenuated vaccine, so you can now give it to pregnant people or like immunocompromised people or people of certain age, above 80. It's a relative contraindication with the age. So that's something to think about as well. Yeah.
So let's go ahead and say, yeah, okay. So we're confirming this is yellow fever. It seems, at least my understanding is people can get really sick with yellow fever. Can you tell me a little bit about that?
Yeah, so most people don't. So actually, most people don't get very sick with yellow fever. But there is, I think it's 20% of people that can get very sick, and those people are the ones that you're not gonna land in your ICU. Once again, it's similar to like dengue. Like it has like a phase that you get these non-specific symptoms, yada yada yada, body aches, fevers, rash, whatever, and then you get better, and then you get bad. You get back again to this immune phase of like severe illness with liver failure, renal failure, and multi-organ failure in a way. And that's when you either, succumb to the disease or recover in many ways. Unfortunately, there is no treatment for yellow fever. I will say the best advice for yellow fever is like if you're going to be exposed to yellow fever, please get your vaccine. I am talking like, and I didn't get it myself. Please do get it. It's very important. But like once you're in the ICU with yellow fever, the treatment will be supportive care overall, and that's about it. and also ruling out all these diseases. As we talk about, so let's talk a little bit of yellow fever. So it's a mosquito-borne disease. It's a flavivirus. The life cycle can be a sylvatic cycle, it can be a urban cycle. So usually it circulates around monkeys in the Amazon area, but with climate change and everything else, and people moving towards more the rural areas and population growing, you can have an overlap between the two. And I believe it's transmitted by the Aedes mosquito, just like dengue as well. But it can have another mosquito who can transmit it as well. And initially a phase of non-specific fevers, and then boom, a few days later you can have multi-organ failure and severe liver failure and severe jaundice. This can lead to recovery and immunity, or it can lead to complete organ failure and death. Best way to prevent it is by vaccination, if available, and the best way to treat it is good supportive care. That's unfortunately as we can say about yellow fever overall. Thinking about other things that can cause it, leptospirosis can give you a cholestatic pattern when it comes to fevers in the traveler. So it can give you hepatitis and multi-organ failure. The syndrome is called whale syndrome. Just like yellow fever has two cycles, right? Initially, you have non-specific fever, febrile phase, and then you can have an immune mediated response that can lead to multi-organ failure, renal failure, and liver failure, and cholestatic hepatitis, as well as severe rhabdomyolysis with elevated CPK levels. Treatment of leptospirosis is different depending on like what options you have. You can do ceftriaxone, you can do doxycycline, depending of what you have. Usually, if the patient is severe enough, you do ceftriaxone. Diagnosis of leptospirosis depends on the stage where you are. If you have an early disease, you can do PCR in the blood. If the patient got antibiotics and you're not quite sure, you can do PCR of the urine, and the urine itself can be positive for longer, and you can do serology. I forgot to say yellow fever. You can do serology and or seroconversion, and also as well diagnose it that way. Thinking about also that for all these arroviruses, there is cross reactivity. So if you test for one thing, they can be test positive for dengue, for example, because there's similarities in the serology. So if you have, for example, Zika or chikungunya, they can test positive for dengue. So the NS1 antigen is different, but like thinking about all this cross reactivity. So not the tests are not really, so specific of one disease, especially when talking about these diseases like Orpuche or dengue, Zika, etc., yellow fever. They can cross react, and you can have positive serologies for different viruses as well. The RT-PCR is more specific, but the thing is like the problem is that when your patient presents to your ICU, it's not actually the virus who's causing the problem; it's the immune response to it. So the viremia is no longer there, or is that relevant anymore?
I think one theme that's relevant to both leptospirosis and yellow fever is they have two phases, and only people who get to the second phase are really sick. So most of the
Exactly.
patients that we're going to see are going to be in that phase where they may no longer be, easy to diagnose.
Yes, yes. And as with any other disease, it's good supportive care and prompt antibiotics when you're thinking about bacterial infection. So you have to have your differential very, very well defined and cover the possibilities that you have there until you have a diagnosis available. Once you have diagnosis available, then you can target therapy to whatever disease. And the answer most of the time will not be vancomycin or vancomycin. It will be something different. So thinking about these things is also very important.
So I think that idea of history and physical and sort of like being curious and remembering how important context is. I mean, those are some really important pearls, Luis, that you've left us, I think, that are generally applicable to all of these cases. Any other, if you had to pick a few other take home points as we sort of come to the conclusion of our recording here, things that you really want our listeners to remember as they go out and use these pearls to take care of their patients, what would you leave them with?
Think about malaria all the time.
All
If
the
a patient
time.
all the time. Patient coming from Africa or Southeast Asia and has severe fevers and severe multi-organ failure is a kind of illness. Think about malaria all the time, 3 times, and rule that out. And if you diagnose it, be prompt about therapy. It's not cannot wait. It's just like any other antibiotic or just should not wait. Ask about it always. So think about if your patient is coming with fevers to the ICU and you really don't know or cannot pinpoint what's going on, an undifferentiated fever always warrants a travel history and a migration history. So where have you lived before coming to the United States is also important, no matter when it was. Think about tuberculosis, even though we didn't talk about it in the our podcast, and it's because most of the time tuberculosis doesn't present as a multi-organ failure. It can indeed present as a multi-organ failure in some patients. So think about it. That I had a patient actually that had 2 trips to the ICU with TB before we picked up TB in the third trip. So it's also
I
very
mean,
important.
you're talking to two pulmonologists here, so we see TB everywhere. I think every time I ride the bus in Seattle, I'm thinking about TB.
Yeah, so think about that. Ask appropriate questions. Think about the incubation period. So what can it be possible? It depends on your incubation period, and that will help you construct your differential diagnosis. And it's okay to go broad at the beginning, targeting things that you think are possible. And the fifth thing will say, always look at different sources and outbreaks of what's going on in the region where your patient came from to actually build your differential and think about the things that can kill your patient. If it's something that cannot kill your patient, it's fine. It's okay. Another thing that we didn't speak about is asplenia. If the patient has asplenia or not, it's also very important. The presentation can change dramatically if the patient doesn't have a spleen or other immune condition. It can be severe and quickly in those patients. And I think
Great
that's
points.
the referrals. Yeah.
Excellent.
Well, Luis, thank you so much for sharing your expertise with us and your time. I think this is going to be an exciting episode for our listeners. Hopefully, they will enjoy all these pearls and take them with them to the ICU and into their practice. This was really great. Thank you so much.
Well, thank you guys for having me. It's been a great honor to be here. And I hope it was helpful. Hope so.
Of course.
I think you've increased testing for malaria, certainly, and hopefully diagnosis too.
Yeah. Good.
Awesome. So thanks again to Dr. Luis Tatem for spending time with us and covering this important topic of fever in the ICU and then fever in the returning traveler. We talked about everything from sort of a basic approach to fever in our critically ill patients. We talked a lot about the importance of context, the importance of getting a really great history and physical. And then we finally dovetailed that with a few specific cases for the returning traveler in the ICU that will hopefully inform your clinical decisions in the future. If you guys want to learn more, definitely check out our show notes and our website, www.criticalcaretime.com. And we've got, all sorts of great stuff there.
Absolutely. And I think, anyone studying for boards, this is probably a very high yield episode.
Yes.
Be sure to check out the website where there's going to be lots of summaries of all the things we talked about. And with that, we come to the part of our show where we'd like to say thanks. Thanks to our amazing guest for sharing his wisdom. Thanks to all the people who have left us reviews, comments, or given us a shout out on social media. We read your comments and we appreciate them. If you like the show, be sure to subscribe. Actually, do us a favor and share the show with somebody else. Send this episode to somebody else to listen to. That really helps us grow. We love to hear from you. So tweet at us or X at us, whatever, at Crit Care Time, or individually at Nick M. Mark, at Askins Razor. Follow us on Instagram, Threads, YouTube, every platform. We are there.
And of course, we want to take this moment to thank our sponsor for Season 2, C-Star Medical. We're fortunate and grateful that this episode and all episodes within Season 2 of Critical Care Time have been sponsored by C-Star Medical. C-Star Medical is advancing the science of cell-directed extracorporeal therapy to help restore the balance of a dysregulated immune system in acute kidney injury and sepsis. Check out their website, cstarmedical.com, to learn more.
We also like to say a big thanks to all members of our podcast team who make this possible, our production team over at Podpaste, and Kurt Belknap for composing the awesome theme music you're hearing now. Quick disclaimer, this podcast and all related media, including but not limited to everything on the website, is property of Critical Care Time. The views and comments in this podcast are not the reviews of our employers. All references to patients or encounters are modified to be HIPAA compliant. And finally, this podcast is for educational entertainment purposes only and should not be used in lieu of seeking an ID consult or qualified medical advice.
Amen.
Yeah. Thanks for listening. I'm Dr. Nick Mark. See y'all next time.
And I'm Dr. Cyrus Askin. Thank you guys. We'll talk to you soon.